Hi everyone, let's finish off the second part of chapter 20, and we're talking about learning disorders and neurodevelopmental dysfunctions. As a quick review, in the beginning of the chapter, we talked about cognition and learning and the processes that are required for a child to deal with input, integration, memory, and output of information. We talked about how important it was to assess for the 8 constructs of the neurodevelopmental model, to look at particular areas of difficulty for the child, and that was on table 20-1, and that includes attention, complex thinking, language, memory, neuromotor functions, social cognition, spatial ordering, and temporal sequestering. We know that most children with academic struggles can have more than one dysfunction that can result in delays in reading, writing, listening, speaking, reasoning, math, and social skills. Learning disorders are traditionally defined as discrepancies between aptitude, which is considered our intelligence, and achievement, which is our learning output on standardized tests, or with the diagnosis of reading disorders, math disorders, disorders of written expression, or learning disorders not otherwise specified. But the DSM-5 has simplified learning disabilities into one diagnostic spectrum with subsets, such as specifiers that will account for individual deficits. And so some of the things that you'll be looking at for in your clinical findings will be difficulty with language processing, visual or auditory processing, memory, motor or spatial temporal orientation. There is a section in the book on common learning disorders in box 20-7. I encourage you to look at this. When you're assessing a child with a learning disability, it's important to do a thorough assessment of risk factors. You're also going to include any screenings. In the assessment component, you're going to be looking for any family history to include any dyslexia or other learning disabilities, any issues with academic achievement, attention disorders, attention deficits, school dropout. You're going to assess for medical history, assessing for birth, issues, any early developmental concerns, head injury, seizure disorders, chronic health issues. You're going to want to assess how well the child connects to school, any description of issues at the school, perceptions of causes of problems, experiences at the school with teachers, peers, homework, coping skills, social competence. You may also want to obtain reports from the school or the teacher that gives information on academic performance, absences, how well have been engaged in class, behavioral information, and any results of any educational testing. You may, in your screening tools, want to perform a school performance pre-screening questionnaire. It's a 5-question survey that you could ask of the student. It's in box 20-8. Asking, are there any concerns about the child's learning or school performance? Any concerns about attention, concentration, impulsivity, or overactivity? Any concerns in certain areas of school, such as reading, writing, or math? Any concerns about how your child is enjoying school compared with friends or classmates? And does your child have any problems completing homework? In your in your differential diagnoses, it's important to consider behavioral and mental health disorders, such as ADHD or anxiety, or any problems that would interfere with social interactions. You're assessing for cognitive limitations and any adverse child experiences. Your role as the PCP is to monitor the child's development from birth through adulthood, with a focus on early identification of any issues that may need further workup. If there are issues of concern, then referrals may be necessary. After a diagnosis is met, the PCP may serve as the case manager. And so it's important that both the child and the family trust your opinion, that you're optimistic, and that there's good education about what the diagnosis is and what treatment options are. We reviewed this earlier, but if there has been a problem that has been identified, Then certain educational support can be offered to the child, such as what we talked about previously with an IEP or a 504 plan. And these are developing plans that are appropriate to accommodate the needs of the child. Family support and social support are very important. Um, you want to help the parents to maintain a positive perspective and have them to be as educated and knowledgeable on the condition as possible. When complications occur, um, you need to know if there's been issues with school distress, acting out, or school failure. And then patient support and family support and education and prevention are very important. It's important that the parents and the family know that exposure to language such as reading and talking at an early age, as early as possible, how beneficial this is. There's lots of programs out there. One that the book mentions is the Reach Out and Read program, in which healthcare providers give books and encourage reading. There's the Dolly Parton's Imagination Library for birth to age 5. So see what resources are available that you might be able to help your patient with. Let's talk a little bit about sensory processing disorders. And we know that the brain and the nervous system function to perceive, integrate, interpret, and then coordinate responses. This can include both visual, tactile, auditory, olfactory, gustatory, vestibular, and proprioceptive information. You may have students and little ones that have sensory disorders but may not have cognitive delays. So some clinical findings that you may note is motor clumsiness, behavioral problems. There may be over-responsiveness. They may have issues with clothing, physical contact, light, sound, food. Under-responsiveness may be a diminished reaction to stimulation, pain, or extreme temperatures. You may have sensory seekers. There may be postural disorders such as floppy babies or dyspraxia, which is poor shape recognition. Those are just to name a few of some clinical findings. With this, an initial assessment of including a history and physical is very important. You are trying to correlate a relationship between behaviors and specific sensory experiences. In your book in box 20-12, there are some red flags for sensory processing disorders, such as with infants and children's problems eating or sleeping, refusing to go to anyone but a specific person. In preschoolers, difficulty making friends, being clumsy. In grade schoolers, easily overwhelmed, difficulty with handwriting. In adolescents or adults, lethargic or slow, leaves tasks uncomplicated. So review those red flags for sensory processing disorders in box 20-12. Some of your differential diagnoses could include, or comorbidities could include, other developmental cognitive delays. You may see ADHD, ASD, or Fragile X syndrome. Management of these kids is early diagnosis with referral and treatment, and complications are going to include lack of friends, poor self-concept, and any academic failures. Let's talk a little bit about the autism spectrum disorders. We know that these are neurobiological and neurodevelopmental disorder that is characterized by patterns of delay or deviance in the development of social, communicative, and cognitive skills that arise in the first years of life. It's characterized by 2 diagnostic domains, so deficits in social communication and interaction across multiple contexts, and restrictive or repetitive patterns of behaviors, interests, and activities. These symptoms must be present in early developmental periods, causing significant impairment, and cannot be explained by intellectual disability, and they are known to cause lifelong disabilities. The causes of autism spectrum are unknown. There's possible correlations to genetic disorders, immune system dysfunctions, and the environment. It can occur in all racial and socioeconomic groups. Clinical findings include concerns in social interactions, noted language problems. There can be an abnormal response to sensory stimuli. In infants, you may notice passive, non-engaging infant, quiet or difficult. It could be colicky, poor eye contact. In toddlers, There can be language delays in preschoolers, social interaction disturbances in school-age kids. Transitioning from place to place may cause issues, and in adolescence, there can be rote learning without any comprehension of the knowledge that they're learning. In your assessment, you're going to want to do some developmental surveillance to assess for red flags of the autism spectrum disorder. And you should also be very in tune to concerns that parents have. A developmental history is essential, and family history may help reveal other components that may help you with your diagnosis. You also want to know if there's been any speech delays or language deficits, mood disorders, or any form of mental retardation. Screening tools are important. There is this chat at 18 to 24 months, the MChat for toddlers, and the CAST for children over 3 years. And those are described in more detail in the book. And as I mentioned earlier, I encourage you to talk with your providers that you're working with about these screening tools that are being used. There may be the need for a specialty referral, as this can be a multidisciplinary team approach. Your differential diagnoses can include those that fall under social and language disorders. One of the key goals in the management of this disorder spectrum is education and helping the parents obtain resources and support. It's important to have an appropriate long-term comprehensive plan of care in place, and this plan is recommended to include 4 components: evidence-based structured educational and behavioral interventions, pharmacotherapy only for specific target symptoms or comorbid conditions, an active role in long-term therapy, and the use of complementary or alternative therapies, providing information for the parents for those. There's been no strong efficacy to show that diet and nutrition changes can impact the disorder. Family counseling and support is important, and then complementary and alternative therapies. It's important that the provider be aware of what the talk may be out and about in the community or the network that the parents are exploring, so that you can speak knowledgeably with the parent about that. When parents approach you with complementary and alternative therapies, it's important to not be judgmental, but encourage the family to thoroughly research the approach that they're considering and know what the specific outcome they are hoping to achieve. And important to encourage them to only choose one option at a time. Okay, let's talk briefly about hearing impairments, and it's a cognitive perceptual problem. And issues are seen in the conductive sensorineural mixed auditory neuropathy spectrum disorders. They can be mild, moderate, or severe, or profound, and are often accompanied by other conditions. Some clinical findings may include delay in expressive skills. You may notice a reduced academic achievement. There may be communication difficulties or social isolation. And when there's hearing impairment, it can impact vocational choices for the future. Box 20-17 offers some red flags. 20-15 offers red flags for hearing loss. In hearing impairment, it's important to complete a thorough assessment, do universal screenings of all neonates, and identify any additional risk factors that may be present. Medical management includes the medical home or coordination of care, using assistive devices, amplification devices. It's important to educate families on early interventions as soon as possible, optimally by 6 months, and then to give family support for the grief and stressors that can be accompanied with the hearing impairment. So we all know that vision relates to cognitive functioning, and that it triggers curiosity, helps integrate information, and invites exploration for more than any other sense. So visual impairments impacts an individual's ability to successfully complete activities of daily life. It can be a congenital or acquired. Impairment is defined as having vision that is 20 to 40 or worse in a better eye, even with glasses. And partial vision is defined as best corrective visual acuity between 20 over 70 to 20 over 200. Legal blindness is distant visual acuity of 20 over 200 in a better eye. And amaurosis is the medical term for partial or total loss of vision. In your assessment, it's important to get a good history. You're wanting to know as much as possible about the prenatal history, their birth history, any history of retinopathy of prematurity. You're wanting to know family history, developmental history for the child. In the management, you're wanting to help promote care coordination. It's important to adapt the environment and provide appropriate stimuli for the child. There will be the importance of assistive devices. These kids, because they're not able to see the sunrise, sunset, etc., may have sleep disturbances, and of course, we know daily living skill challenges. Management includes education, early intervention, IEPs for school, and then it's important to assess, offer support for the family with grief and stress. That's the end of section 2.